Hello students, welcome to today's session for radiology. Topic types of intracranial hemorrhage and tram track appearance in various conditions. The first topic for today is types of intracranial hemorrhage. As you know, it is divided into intraaxial and extraaxial hemorrhage. Intraaxial is generally seen in the parenchyma. Within the parenchyma, we'll be appreciating it as a contusion. If it is extraaxial, that means outside the brain parenchyma, it is divided into epidural, subarachnoid, and subdural. So we'll see each of these conditions under the headings for what is the source, what is the cause, and what are the clinical features and CT findings and the treatment. First, coming to the subdural hematoma. So the source of the bleed in subdural hematoma is subdural. It is venous. Bridging veins are ruptured in generally alcoholics or elderly people who are having frequent falls, and patients on anticoagulants also tend to have subdural hematoma. In infants and children, it is more common in child abuse, where a condition it is called as shaken baby syndrome. How are they presenting? So subdural hematoma, if they are acute, then they will be presenting with lucid interval, whereas in chronic subdural hematoma, they will be presenting with drowsiness and headache. The buzzword in CT findings is the crescent shaped blood attenuation area seen in the periphery. So, what is the treatment for subdural hematoma? It may resolve spontaneously if it is small, but if it is very large and it is causing mass effect and midline shift of the brain parenchyma, then we have to intervene and it requires surgical drainage. Next, coming to the epidural or extradural hematoma. The buzzword here is a biconvex shape, as you can appreciate here. This is the biconvex shape. The blood is between the dura and the skull. Why is it caused? It is caused because of tearing of the middle meningeal artery. It is generally seen in adolescents and young adults. This is also seen because of trauma. There is fracture of the squamous part of temporal bone, and this lens shaped or lentiform shaped or biconvex is the buzzword that you have to remember, and they present with a lucid interval. What is the treatment? This is a surgical emergency, so surgical evacuation has to be done, if especially if it is large and evolving EDH. That means the blood is getting accumulated fast enough to cause symptoms in the patient, and the condition of the patient deteriorates. Another condition, it is called as acute on chronic. That means there is a chronic SDH. If it is chronic, what happens? The blood in this region will start to sediment, and it will give us blood attenuation in the lower area and the plasma on the upper area. This is the hematocrit kind of thing, which is causing this blood attenuation in this area, which is giving us a fluid level. So, see, this is plasma, it is not CSF, because CSF is even way more dark, and this is the plasma seen in the acute on chronic subdural hemorrhage. So generally this is seen after a acute insult, after the patient is having a chronic subdural hemorrhage. Next, coming to subarachnoid hemorrhage, the blood is seen in the circle of Willis, cisterns, and the fissures. It is generally due to rupture of the berry aneurysm, and it is seen in polycystic kidney disease, which is a risk factor. The source is arterial here, that is, the berry aneurysm is nothing but the arterial aneurysm which is ruptured. The most common site is the terminal ICA, MCA bifurcation, and top of basilar artery. The clinical features is classical. There is a thunderclap headache. It is described as the worst headache for the patient in their lifetime. And CSF on lumbar puncture will show xanthochromia. That is, there is yellowish tinge of the CSF, which is classical for subarachnoid hemorrhage. And the subarachnoid spaces are completely filled with blood here, as you can appreciate. The sylvian fissure and everything is filled. So what is the treatment? So as you know, there is aneurysm, so it has to be clipped, coiled. So that is a definitive treatment. But for meantime, the medical treatment is triple H therapy, that is hypertension, hypervolemia, and hemodilution. So that will prevent the vasospasm that is caused because of the blood in the cisterns in the arteries. So we are trying to avoid the vasospasm in the arteries because of the subarachnoid hemorrhage. So next, coming to the intracerebral hemorrhage, as we have already talked, it is most common cause of intracranial hemorrhage is hypertension. The hypertension is will cause bleed in the putamen most classically, and the territory is penetrator arteries. The blood in the parenchyma and ventricles can be appreciated. If there is blood in the ventricles, it is a bad prognostic indication. The most common site, as I've already told you, putamen of the basal ganglia. What is the treatment? So, correction of any identified coagulopathy by infusing prothrombin complex concentrates, FFP, or fresh platelets is required. Surgical evacuation is required if there is cerebellar hematoma, which is more than 3 centimeters in the site. Okay, next coming to the important feature, the epidural hematoma and subdural hematoma have to be distinguished. So, subdural hematoma, as you know, it is between the before the subdura. So, dura is attached to the skull and it cannot cross the falx or the tentorium. So, the subdural hematoma does not cross the falx, whereas epidural hematoma is rapidly expanding arterial bed due to the skull fracture, as I've told you, the squamous part of temporal bone. It is because of the middle meningeal artery is ruptured. So the dura is pushed away from the hematoma and it will cross the sutures, it will cross the falx. Next, coming to the differences of epidural hematoma and subdural hematoma. Epidural hematoma, as you know, it is because of the skull fracture and it is because of the torn middle meningeal artery. So it will push the falx away and it will cause a biconvex shape. So this is the falx lining, so it will not cross the suture. Whereas subdural hematoma, it is slowly expanding venous blood that is below the dural attachment, so it cannot cross the falx. It is the important difference between epidural and subdural hematoma. Okay, this is the overall. This is a healthy brain. This is the slight evidence of blood attenuation seen on the periphery of the skull, where we are able to see a crescent shaped area, and this is biconvex shaped EDH, and this is the intraparenchymal hemorrhage with extension into the ventricles, and this is only solely intraventricular hemorrhage, and this is the basal cisterns filled with the blood, that is subarachnoid hemorrhage. Coming to the next topic, tram track appearance in various conditions. Tram track is nothing but a railway line. It is a tram track way. So in various conditions, we see this tram track. So let us go and check it. In pulmonology, when found in lungs, it is because of pulmonary edema, especially in cases of congestive heart failure and bronchiectasis. The tram tracks are caused because of the bronchial wall thickening. That is, the wall of the bronchus is thickened. That is, this is the bronchus and the wall is thickened. So it looks like a tramway or a railway lines. So you're able to appreciate here. This is the one line and this is the other line. This is because of the bronchial wall thickening. Here is another other example. This is the tram track appearance here, and it is also seen in cases of bronchiectasis, where we'll also give another sign, that is bunch of grapes sign in cystic bronchiectasis. Tram track appearance is also seen in bronchiectasis cases. Coming to neurology, the optic nerve sheath meningioma. This is the optic nerve which is covered with this is the optic nerve and this is the meningioma which is covering it. Optic nerve sheath meningioma also gives a tram track appearance. Next, in CNS, there is another condition called as Sturge-weber syndrome. So what happens in Sturge-weber syndrome is that there is calcification, cortical calcification seen, which give a tram track appearance. This is the tram track appearance that we are able to appreciate. So the cortical calcifications in Sturge-weber syndrome are also called as tram track. The other clinical features for Sturge-weber syndrome are seizures, tram track calcifications, unilateral port wine stain, and contralateral weakness. R for retardation, mental retardation, G for glaucoma, and E for epilepsy. So it is important for us to remember the mnemonic for Sturge-Weber's so that you'll remember it easily. Seizures for S, T, tram track calcifications, U, unilateral port wine stain and contralateral weakness, R, mental retardation, G, glaucoma, and E, epilepsy. There is another condition where we see tram track appearance. This is a USG of the breast where we are able to see the mammary glands. This is the mammary gland which is filled with fluid. This is the condition duct ectasia, that is, the duct is dilated and there are secretions within it, which also gives us a tram track appearance. Thank you.